about kind of the spectrum of hip care today. I come to things from the spine side, obviously. The three of us work together frequently, kind of bouncing patients to the appropriate one of us, because the question comes up every single day I see in my office, patients who come to me and they say, I don't know, I got like pain here. Am I in the right spot? Is this my hip? Is this my back? And it's not an easy question to answer always, and sometimes even for us, and that's why we kind of work together as a team. What I'm going to focus my lecture here today is on the things that make me think that it's coming from the back. Versus the hip. It's just to kind of try to help you guys wrap your minds around what might be going on in your own bodies. And we'll talk a little bit about techniques, but those are really varied with spine, and we'll kind of save that for the end. So anyhow, here we go. So is it your back? Just some background material. Back pain is extremely common. So patients come to me and they say they have this back pain, and they're worried, and I say it's almost more strange if you don't have back pain, because 8 out of 10 Americans have significant back pain at some point in their life, bad enough that they go see a doctor for it. So only 20% of people don't. So if you don't, I guess you can pat yourself on the back, but not too hard. Don't hurt yourself. So this just gives another idea. So back pain is actually getting more prevalent with time. And so within the last 3 months, about 30% of people say they've experienced back pain. So this is something that happens frequently. It's more frequent in patients older than 65, usually because arthritic type wear and tear changes are setting in. But 18 years and over is pretty close too. So the whole spectrum of people can have back pain, and this seems to be increasing with time. So what happens? Just because you have back pain obviously doesn't mean you end up having back surgery. 90% of people have their symptoms resolve within 6 weeks. So just because your back hurts doesn't mean your back's going to hurt forever. And as I tell my patients, my goal is to have you feel better and be functional without needing surgery. And the vast majority of patients, that's a total reasonable possible thing for them to have. Say you have an episode of back pain, it goes away. What's the chance that you'll have another one? Well, 60 to 80% of people will have another episode of their back pain within a couple years. So it's not uncommon that you have these flare-ups and they go away. And then over the long term, only about 7% of them develop chronic problems. So just because you have an episode of back pain or a couple episodes of back pain doesn't mean that you're doomed to have this fate of back pain. But some people do fall into that category of having persistent spine-related issues. Interestingly, 9 out of 10 people who have back pain never really even figure out where it came from. Does it really matter? Probably not, because it goes away. But part of our job, if it's persistent, is to figure out where it's coming from and how we can help you feel better. This is an interesting study that came out. It was actually out of the Middle East. They looked at 1,100 people with back pain, and then they did kind of a comprehensive evaluation of them and tried to figure out where that back pain was coming from. And 61% of them, it was coming from their back, right? That's kind of generic and maybe predictable. But a significant number, that means 39% of people had something else going on. And relevant to our talk today, 6% of them, it was their spine and their hip. And 4% of them, which is a sizable number of people, it was their hip alone. So they had no problem with their back whatsoever, and it was their hip that was causing their symptoms. So let me go through the things that make me think back. So I have that person, they come into my office, they've got kind of non-specific pain, and I ask them a bunch of questions and do an exam, and we'll go through some of that stuff. So pain that radiates from the back down the leg, sciatica type pain, and especially below the knee, is much more likely to be coming from the back. Now, hip pain can radiate down, obviously around the hip area, but rare, and even down to the knee, by the way. So a lot of people experience knee pain that's referred from their hip. But if it's going below the knee, it's very unlikely to be coming from the hip. Pain from the back usually runs all the way down, like a line all the way down the leg. Pain from the hip is usually here in the front. Not always, but Dr. Homan over there taught me the C sign last year when we were doing this, and I use that. So if patients go like this, I have pain here. It's like this. That's usually a hip-related problem. Not always, but usually. There are some nerves in the upper lumbar spine that do wrap around this area, but pain in this area here is very frequently the hip. And as Dr. Rayner alluded to, pain right here, right on the side of the hip, worse when you sleep on that side, that's very frequently bursitis. That's super, super common. So I'm sure all three of us see that all day, every day. And the good news about bursitis is there's extremely low chance that you need an operation. It's a very common thing. It's an inflammation in the basically the padding over the hip bone. Some physical therapy, anti-inflammatories, sometimes an injection makes that go away. So certainly not spine surgery, and very rarely surgery at all for that. But anyway, pain radiating down all the way below the knee, that makes me think back. How about this, pins and needles? So not just pain, but numbness, or it feels like parts of your body, or your legs particularly, are going to sleep. That's less likely to be related to your hip and more likely to be related to pinching of a nerve, particularly in your back. Now, an important distinction to be made is between sciatica type pain and something called peripheral neuropathy. So patients, especially with diabetes, but you can get it for other reasons, can get this numbness and tingling. It usually starts in their toes and works its way up as it gets worse. Whereas problems from a pinched nerve in their back usually start in the back and work their way down. So patients who come to me and they say, yeah, I have numbness and tingling from my ankles down, that makes me think that's probably a neuropathy problem, not directly related to the spine. Whereas if it goes the other way from the back down, that makes me think more of the spine. And obviously there can be overlap between these two things, but that's kind of a ballpark thing that you can think about. How about weakness? So weakness in your legs. There's some overlap. This is a common theme between hip problems and back problems. And if you have hip pain, you can have perceived weakness because the pain makes you not want to lift your leg or move your leg. But actual weakness of the muscles, atrophy of the muscles, muscles wearing away, wasting away, that's usually coming from a pinched nerve in the back that can reduce basically the signals to the muscles. And any weakness that's below the knee is not coming from the hip. So difficulty raising the toes or pushing down with the ankle, that's more likely to be a back problem and less likely to be a hip problem. Back pain with sitting. So usually the back pain, or the pain associated with, say, hip arthritis is worse when they first stand up or as they're walking, they get their pain. But pain sitting down in the back is usually associated with a disc problem. So oftentimes younger people have issues with their discs, and when you sit, it puts more pressure on the discs, which are kind of in the front of the spine. So people who say to me, yeah, it really kills me when I'm sitting down, that makes me think, probably a back problem, it's probably related to the discs. This is a little bit of a different category. So younger people tend to get disc problems. Older people tend to get spinal stenosis. And stenosis means pinching of nerves, and it usually has to do with kind of an arthritis-type process that happens in the back. So bone spurs and overgrowth of the soft tissues that presses on the nerves. And the typical pattern for people with spinal stenosis is they'll tell me, I'm pretty good when I'm sitting or I'm laying down, but when I stand up and when I walk, especially when I try to walk distances, I find that I have increasing pain in my legs. My legs feel heavy and kind of weak, like I'm dragging my legs through water. And what I have to do after I walk a set distance is I have to sit down. And if I sit down for a minute and kind of compose myself, things go back to normal, then I can stand up and walk further. That's a very classic story for what's called neurogenic claudication, which just basically means the symptoms of spinal stenosis, pinching of the nerves. People also, the picture here is, we call this the shopping cart sign. And so patients say that, they can only walk a block, say, but if they're at the grocery store and they lean forward on the shopping cart, they're able to walk further. And they don't have that heaviness in their legs. And the reason is, for anatomic reasons, by leaning forward, it gives their nerves a little bit more room to breathe, if you will, and they're able to walk further. So that kind of story makes me think, coming from their spine, probably a stenosis type problem. And then flexibility. So I examine all of my patients. So patients who have severe hip arthritis cannot do this. So it's probably coming from their back. I'd be very surprised if she has a hip problem. And that comes back to the physical exam and the maneuvers that we do in the office to try to figure out what's what. What other tools do we have? I mentioned, listening to the patient, which honestly is probably the most important thing. The story that the patient tells me before I even lay hands on them to examine them, I already have an idea of what I think is probably going on. But it's the listening to your patient, examining your patient, and then we have imaging that we can do. So X-ray is always the first step. X-ray is really important. A lot of patients will come to me and say, but I already have an MRI. Why should I have an X-ray? An MRI is better. Well, each of these things gives us a different piece of information. MRI is actually very important, but it's performed laying down typically. X-ray is performed standing up, and so I really use the X-ray to look at how the patient's posture is and what their alignment is with them standing up. And a lot of people actually have instability. So how they stand is much different than how they look laying down. And that's really a big benefit of the X-ray. So we start with X-ray. If we need additional information, MRI can be very helpful. MRI really looks at the soft tissues, so the discs and the nerves. I can diagnose disc herniations and spinal stenosis and other kinds of things that might be causing them issues. And then this thing on the right is a CT scan or a CAT scan. And that's like a 3D X-ray, and that shows me the bones in high detail. And so sometimes, depending on the problem, that can be beneficial as well. And then we have each other here. So as I mentioned, we frequently will get on the phone, talk to each other, send patients back and forth to try to figure out what the relative contribution is of their back or their spine to their symptoms. And in complex cases, sometimes we'll talk about, if we need to address both, who should go first, how can we modify our surgical plan so that we set them up for success with the next person. And so it's really important to have this tight network of friends and colleagues who you can work with to take care of patients. It's really hard to get us all together in the same place. This is one of the few times ever, so I photoshopped us here. If you see us actually standing next to each other, I made myself taller than I really am. But I would have literally had to crop this differently because I come up to about right here. So say you have a back problem. We've gone through this and we've determined that at least some of your symptoms are coming from your back. What do we do? Well, I tell patients every single day, I say, I'm a spine surgeon. I love to do spine surgery. But what we're going to talk about today is not spine surgery. Because for me, spine surgery is a last resort. My background, as Leslie alluded to, is all minimally invasive techniques. And the least invasive spine surgery is no spine surgery. And so that's always my goal with every single one of my patients. I treat everyone like a family member. And while I think that spine surgery is magical and can do great things, it's only a last resort. Because if you can get somebody better without spine surgery, and in the majority of cases we can, then that's a win for everybody. So what are some of these things that we can do? It's kind of a progression. So you start with the least invasive, most conservative thing, and if necessary, you work your way through the process. So the first kind of phase of stuff is physical therapy. Physical therapy can be really beneficial for a number of reasons. By strengthening the core muscles, you can take some of the pressure off the spine and the joints and the nerves and give people a lot of relief. And the other thing is, as people get older and they get arthritis in their back, they stiffen up. And so by keeping them moving, you can keep them from having this kind of stiffness type pain. Because the problem is you get stiff and then you don't want to move, so you don't move, and then you get stiffer, and it's this kind of vicious cycle. And physical therapy can be very effective in getting people out of that. Medications can sometimes be helpful. I advocate for anti-inflammatory type medications, Advil, Motrin, Aleve, ibuprofen, meloxicam, as long as there aren't any medical reasons not to take them. Those are usually the best medications for kind of arthritic type pains. Heat and ice can be beneficial. Time can be beneficial. So as I alluded to, a lot of these episodes of pain go away within 6 weeks. So trying to help the patient be as comfortable as possible while their own bodies take care of things. And then usually doing some physical therapy exercises indefinitely at home to prevent things from coming back can be effective. And then, that's kind of the first phase of stuff. And then if that doesn't work, we will often get an MRI, look into things further, and think about maybe an injection or something like that. Injections are frequently cortisone, which is a strong anti-inflammatory, targeted right to wherever the site is. A lot of people say to me, oh, an injection is just a Band-Aid. It worked for my neighbor, but only for 1 hour. Like, I don't want to do that. Everyone's different. There's a lot of different types of injections, and they do different things. But some people can get long-term relief from an injection. So I frequently feel like an injection is warranted, depending on the problem, especially if the next step is surgery. So, you know, it's worth trying an injection. I think they're usually beneficial, and they give us information. But what happens if all else fails and you end up still unhappy, still uncomfortable, and we need to talk about spine surgery? Well, the fortunate part about it is this is not what we got anymore. So, you know, patients come to me and they say, well, my brother had spine surgery 15 years ago, and he's had 15 spine surgeries since then, and everyone I know who's had spine surgery says to me they wish they didn't have spine surgery, and they're worse off, and they're still taking pain meds. And they curse their spine surgeon every day. Well, I don't blame them for saying those things, because the traditional way of doing spine surgery is days and days in the hospital, sometimes longer than that, pain pumps, IV pain meds, etc. And the reason for that is because the traditional way of doing spine surgery, which is an incision down the center of the back, and stripping, really burning the muscles off the back to get to the spine, is extremely damaging. And so people end up with long-term problems associated with just getting to the spine. My background is minimally invasive techniques, so this is what gets me excited. I literally think about this when I go to sleep. I think about it when I wake up in the morning. This is what I'm really passionate about. And the key to minimally invasive is not just making small incisions. So I make the smallest incisions because I think that's cool. But the key to minimally invasive is not disrupting the soft tissues under the skin. So preserving the muscle, preserving the ligaments. So no matter where I am, in the neck, in the low back, front, back, side, wherever I am, whatever I'm doing, I do not cut muscle. And that's the key. Because the key to bouncing back quickly is preserving those structures. So it's getting to the spine, doing whatever I need to do, doing the smallest surgery I can possibly do, but getting there through small incisions that are muscle sparing is the key to minimally invasive. As a result, I'd say 75% of my patients go home the same day as surgery. So I'm trying to really change the typical thought process around spine surgery, make my spine practice a lot more like Dr. Rayner's sports practice, where you come in, you have your tune-up, you get the problem addressed, and you go on with your life. So my patients, most of them are going home the same day. 98% of them go home within 1 day of surgery. So maybe an overnight stay and then home the next day, up walking around. There's a bunch of different techniques. I won't bore you with all the details of all of them, but one that I'm particularly excited about that Leslie alluded to is the endoscopic techniques. So rather than the traditional way of doing surgery, or even the traditional minimally invasive surgery, which involves small incisions but still looking directly down to the spine, endoscopic surgery involves making an 8mm incision, introducing a camera down into the spine, which we call an endoscope, similar to what Dr. Rayner does in the hip. And then through that camera, I'm able to either shave down bone spurs or remove disc herniations, basically take pressure off nerves without destroying or damaging the muscle really at all. It's really incredible. If you take an MRI of someone after they've had the surgery, you can't even tell where the camera went in because there's really no evidence that it was there at all. As a result, the camera comes out at the end of the case. The nerves no longer have pressure on them. Patient gets 1 stitch under the skin and goes home like an hour later. So really not what we're talking about here. Interesting, my grandfather had a microdiscectomy, which is a similar surgery to what I just described 30 years ago. And he was in the hospital for 2 weeks. The surgery hasn't changed with the exception of these endoscopic techniques much since then. But my patients are home within 2 hours of surgery. So really best for the patient, and the outcomes have really been phenomenal. So that's part of it. I do a lot of different things. Endoscopic techniques are not applicable to everything. I also do disc replacement. And even in some cases, fusion is necessary in some cases. I try to avoid fusion if at all possible, but there's minimally invasive ways to get that done as well. So even my fusion patients tend to go home the following morning after surgery. Oh, minimally invasive. So yes, so I'm doing basically Band-Aid type surgery. And this is the future. So this is my son. He's 2 years old now. He's a little bit bigger than this, but he can't fit into his scrub, so I still use these pictures. So that's my talk.